All right, so we're going to go ahead and get started. I'm going to hand it over to Amy Litterini.
Thank you very much. All right, everyone. Good afternoon. Thank you for being here, although I know I made my PT students be here, but I'm glad that you're here. I'm glad everybody is here. And I have to say, this is my favorite day of the year. And for me to be back with Dr. Palladino and Allison for today's session is really an honor and a privilege. So what I wanted to start off with was just sort of a state of cancer survivorship. And so my background is as a physical therapist, but also as a lymphedema therapist and a cancer patient navigator. And so I was blessed to work with Dr. Palladino for a few years doing that and working very closely with breast cancer survivors. And so I wanted to just sort of set the stage with a few terms just so that we're all sort of on the same page. So when we talk about cancer survivorship, there is a technical definition of a cancer survivor, and essentially it's from the day of diagnosis throughout the balance of life. So some cancer survivors think they have to sort of wait till like a 5-year mark and then they can call themselves a survivor. And that is not true. And I have heard Dr. Palladino eloquently and compassionately give many diagnoses of breast cancer, and it's not an easy thing to do, but from that moment, life changes for that survivor for sure. So one thing to think about though is 16% of cancer survivors already have another cancer history prior to a new diagnosis of cancer. So I had a gentleman at one point for Cancer Survivorship Day call me and he said, "I'm new to the area, I saw your Cancer Survivorship Day in the newspaper, can I come join you?" And I'm like, "Well, I don't see why not." He said, "Well, I have 7 different types of cancer, so I think I might qualify." And I said, "Well, at least we owe you a burger. I think you should come to Cancer Survivors Day." So he came to Cancer Survivors Day and became one of our patients. But so it's not inconceivable that there are multiple cancers in the same individual. So when we think about cancer survivorship in the United States, it is not an insignificant problem. There are large numbers of survivors out there who need your care and attention. And the more awareness you have about oncology, the better. And so when we think about the numbers, presently the estimates are 14.5 million. The projections are for very soon to be 18.1 million in 2020. And that is at a cost in 2020 of $173 billion. So it is something that is quite an expenditure in the healthcare system. And lots of survivors needing your care. So this is just an illustration of what that looks like, and ultimately the growth in our technologies and our effectiveness with treating cancer has led to that, but there have been a few other things that we'll talk about here in a second. So when we think about the length of survivorship, that's also something for you to consider. So the total number of survivors is one thing, but survivors are surviving longer with their existing cancer history. So if you look at what used to happen back in the 70s versus what the projections are for 2022, the number of years of survivorship are going up. So you're going to have patients that are getting older with the survivorship history, and so be aware of that as well. So when we think about cancer survivorship, it's not just about time, it really is about quality. And so there's lots of things we do in oncology to not just increase the duration of time, but it has to have quality associated with it. So essentially it's lifespan after cancer. They call it the health span. We want that time to be spent in the healthiest way possible with the greatest quality of life. So essentially that's what we're looking for in our treatment. And so when we think about some of the reasons why we have more numbers of survivors that are surviving longer, the couple of main reasons for that is that we're better at catching cancers. We're better at diagnosing them early, so we have our diagnostics improving. Our treatments have more efficacy, and we're better at following up with our patients. So, you know, back not too long ago, we used to say to a patient, "Okay, you're done, congratulations," and we might see them for, you know, follow-up, but we weren't looking as closely for some of the side effects of cancer treatment and some of the things that cancer survivors can face. And now we are more diligent with that, and that has improved. But our patient population in this country is getting older. I know you all are very well aware of that. And we also have issues with patients being overweight and obese, statistically speaking. And so there are many cancers that are correlated with that as well. So when you think about those rising numbers, some of it is it's an epidemiological change in the demographic of our patients in the country as well. So many of you I know want to treat pediatric patients, so there is a spectrum of cancer survivorship, and the different age groups that we ultimately are able to improve their health and quality of life. We have the pediatric patients. There's also a group called AYA, the adolescents and young adults. our adult patient population, and really geriatric patients. Pretty much by 2040, they're estimating that 73% will be over the age of 65 as far as cancer survivors are concerned. So an awareness of geriatrics is also important with our aging population. And this is just an illustration of that we know that by age, we do have a majority of our patients that are in that 65 and over. So being knowledgeable about some of the sort of concurrent comorbidities that our patients that are in that age group can have is an important thing. So when we think about cancer survivorship, there's a spectrum, if you will, of when, in community health, we try to prevent cancers to the best of our ability. We try to detect them early when we can, get an accurate diagnosis, an effective treatment, and then for patients when they're done with treatment, they can move into essentially acute survivorship and or long-term survivorship, but then there's also end-of-life care. So when we think about the entire spectrum of life from prevention in the community to end-of-life care, survivorship has quite a continuum. And so oftentimes in the medical profession, we are involved with right from that diagnosis point forward, but obviously community health is key at catching the cancers early and hopefully preventing them. So our cancer survivors have a lot of challenges that they need to face, and they need us to face them successfully and help them with them. So I won't read this list to you, but essentially there are a lot of treatment-related side effects. So whether they're associated with surgery, chemotherapy, radiation therapy, hormone therapy, other issues associated with their treatment, and sequelae from their treatment, things like lymphedema or neuropathy from chemo. Some chemos cause cardiopulmonary issues. Most all of our patients have fatigue. That is the #1 complaint in cancer survivorship. So there's lots of issues that they have, but the concerns they have, really, these are individuals that have a transition to illness. So I know in social work that phrase is commonly used to say you had somebody who was potentially well today and now they are considered or consider themselves unwell, and they are mentally transitioning to that diagnosis or transitioning to becoming a cancer survivor. So there's distress associated with that, there's fear, there's anxiety. A lot of our patients have sleep disturbances, they're at risk for depression, so we have to be very sensitive about what their experience is. And it's not just the patient, it's also the family and the significant other. So it takes a village, so I'm glad you're all here. So essentially when we think about our sort of rehabilitative strategies, and that's all of us, it's really when we think about, we have a moment when patients are before treatment. So I was fortunate to meet most of Dr. Palladino's newly diagnosed breast cancer survivors at the time when they had a positive biopsy on pathology. So we knew what they had on a cellular level, but we have not done treatment yet. So that's a really good moment for educational purposes to be able to talk about what to expect and to be able to meet people at that point. There's lots of patients that you'll see in active treatment, but then they move on to maintenance. Some go into remission or they're post-care, or they need ongoing care for palliation. So there's sort of these different moments of time that we can be involved with these patients. So as I said earlier, we used to sort of say, well, congratulations, you're done with treatment and we'll see you in 6 months. Well, we have realized that that's probably not enough and that's not sufficient to really find out what is most at risk for this particular patient and to diagnose it early. So now there have been some mandates on things called survivorship care plans and treatment summaries where we leave a patient with, this is what we want you to do. These are the diagnostic tests we want you to have. This is the treatment that you did have, and these are the risks associated with that treatment, so that we have a patient who leaves us in the most educated fashion with a plan that they know what to expect and they know what to follow up for. And so, again, it takes a big team. It takes all of you. It takes everybody in this room. And essentially, if you're fortunate enough to work at a comprehensive cancer center who has a lot of these resources available, this is an amazing team to be able to work with. So I was very lucky to essentially have everyone on that list to be part of the team to help provide survivorship care. So when you think about the different types of clinics and wherever you work, if you don't have a seat at the table, there's a saying, if you don't have a seat at the table, you're on the menu. So my advice to you is if you go work somewhere and you are not involved in cancer care at that organization, or your discipline is not, or you could be involved more. I would encourage you to advocate for your profession because you're really advocating for the patient. So what you can help that patient with, be present and be available and make yourself available. But there's also a lot of learning opportunities. If you have a chance to sit in on a multidisciplinary breast clinic or a tumor board or something like that, I would encourage you to do that because there's a tremendous amount of learning that you can do from that. Programs that can be started. We had some weight management programming, we had some wellness programming, lots of different clinics and multidisciplinary opportunities. So there are guidelines out there. So much of what I'm telling you is it's not personal opinion. We have now mandated by many national agencies that these are the things that we should pay attention to with this type of cancer survivor, and that we need to be doing a thorough job of sending them off or monitoring them if they're in ongoing treatment. So all of these entities list various guidelines that are out there for best practices. So just know that you can take a look at those at any time. And so when we think about community collaborations, if you work in a cancer center, you work within a community, you are part of that community. And so my encouragement to you would be to participate and be engaged with things that help the community as far as awareness, fundraising, advocacy, anything that you can do to be part of that is really a wonderful thing. And we have a good example here with Allie and Diane. So I know Allie's going to tell us a little bit about her story, but I'm going to minimize for right now and have Dr. Palladino come up to speak with you. Dr. Palladino came to us in Exeter, New Hampshire from Philadelphia. We stole her away, and I think she was happy that she came. I don't know if there's anything on that first slide, but I'll go ahead and start there. Oh, here it is. It wasn't coming up on the screen. So without further ado, my colleague and friend, Dr. Diane Palladino. Thank you. Good job.
Thank you. I just want to switch gears for a short minute and say that after the events of this week in Las Vegas, I want to thank you all especially for entering the healthcare profession. Thinking about those trauma surgeons, I remember my time as a trauma surgeon, and I just felt this overwhelming sense of being blessed to be able to be in the medical profession and step up to the plate in these terrible events. So thank you. Be the best you can be. Amy asked me to teach you all about breast cancer in 20 minutes. I'm not a magician. I'll do the best I can. I'm going to start with, I especially want to tell you about some of the newest things going on in breast cancer. We'll start a little bit with how breast cancer starts. And the hot topic now is the genetic mutations. So it's the Angelina Jolie syndrome. There are two major gene mutations that are responsible for breast cancer, BRCA1 and BRCA2. They also increase the risk for ovarian cancer, prostate cancer, melanoma, and pancreatic cancer. And they're responsible for about 5 to 10% of all breast cancers. The black slice, there's an alphabetic soup of gene mutations that are responsible for the black pie. Things like ATM, CHEK2, PTEN. And we used to just test for the BRCA genes, but now we have a genetic profile panel that's done, which gives us those other genes as well. These are some of the risk factors for breast cancer, and as you can see, the patients who carry a BRCA mutation have a markedly increased risk for the development of breast cancer. Other things like chest wall radiation, those are patients who maybe had Hodgkin's disease and got radiation treatments to their chests. Those are usually young women, and they have an increased risk for the development of breast cancer just because their breasts were irradiated. Increased breast density is felt to be an increased risk factor, probably because breast tissue that is very proliferative, very active, causes dense breasts on mammography, and also because breast cancers are more difficult to detect in dense breasts. Breast cancer shows up white on mammogram, dense breast shows up white on mammogram, so it's hard to see white on white. In older women, the breasts become fatty replaced. Fat shows up black on a mammogram, so it's easy to see a white dot in a black background. Atypical cells in the ducts increase the risk for breast cancer by at least 4 times. Never being pregnant or a late first pregnancy, early menarche, late menopause, it's that long stretch of unopposed estrogen. So as you can see, the pink and the gray are the average population, but if you're a BRCA carrier, instead of having an overall risk of maybe 12%, you're now up to over 80%. And the risk for ovarian cancer in this syndrome, it's called hereditary breast and ovarian syndrome, is also markedly increased. You can see from 1% to 44%. That's the real killer. So the recommendation, if you are a gene carrier, is once you've completed childbearing that you have your tubes and ovaries removed. You need to take the tubes too, because there can be ovarian cells within the tubes. But as you can see, most breast cancer is what we call sporadic. So the hereditary is only 10%, familial increases that number, but the gray ones are, it just happens. And so a lot of people come to me and say, well, I don't have to worry about breast cancer. I don't have a family history of breast cancer. Obviously, that doesn't take you off the hook. Most women who are newly diagnosed with breast cancer have no family history of breast cancer. This slide I thought was very poignant. I got this from my main source of medical information, the New York Times Science magazine. And what this points out is that Ashkenazi Jews have a very high risk for being BRCA carriers. These are the red flags for people who might be a carrier of the gene. So we look for all these things when we evaluate a new patient with breast cancer, so we can decide who should be sent, who should have genetic testing. Triple negatives, male breast cancer, BRCA carriers can often have more than one breast cancer, and they can often have bilateral cancer. So what do we do about these patients? Surveillance is an option, and as that picture of the woman with the lumpectomy shows, she did not have bilateral mastectomies as Angelina Jolie did. She chose to preserve her breasts, which is very common in Israel. Here, if you're a BRCA carrier, most women are like, get them off. But in Israel and in other countries, surveillance is still an option rather than prophylactic mastectomy. So you can still, if you have breast cancer and you're a BRCA carrier, you can have a breast conservation and the usual breast cancer treatment, and then just increase surveillance with yearly MRIs. Prophylactic surgery is very popular for BRCA carriers. Again, sometimes we combine the bilateral salpingo-oophorectomy with the bilateral mastectomies at the same procedure. This decreases their risk for the development of breast cancer by about 97%. It's not 100%. You can never get rid of all of the breast tissue. If you do a mastectomy, you'll see breast tissue sometimes going right up to the dermis of the skin. And so you can't remove it all. So it doesn't drop the risk to 0, but it brings it down significantly. If you carry the gene and don't have breast cancer, we recommend that you examine your breasts once a year, you have a clinical breast exam once a year, and you have a yearly mammogram and MRI from the age of 30 on. The MRI and mammogram we usually stagger at 6-month intervals, so we're looking at the breast twice a year. And then chemo prevention, there are anti-estrogen medicines that you can take. They're called SERMs. You've probably heard of tamoxifen and Avista. They will decrease the risk for the development of breast cancer. there have been studies done in high-risk women who've taken tamoxifen, and they have about a 40 to 50% decrease in the risk of development of breast cancer. Any questions on that? Real quick. So breast cancer treatment, here we go. Fasten your seatbelts. There's two things we want to think about: local regional control and systemic control. How do we treat the tumor itself? We used to treat breast cancer with what was called a radical mastectomy. We've now gone down to lumpectomy. Lumpectomy is usually combined with radiation. The high energy beams from the radiation kill cancer cells. They also kill normal cells, but cancer cells are actively multiplying and dividing and are better targets for radiation. But normal cells also get injured. Mastectomy is still an option. Some women still opt for mastectomy, and in fact, mastectomy rates are increasing in our country, mainly because of fear of recurrence and fear of the use of MRI, which we'll talk about later. But the survival rates for lumpectomy and radiation and mastectomy are the same. So it sometimes becomes a patient's choice. Sometimes there is no choice. If the patient has disease in multiple quadrants of their breast, or we don't feel we can obtain a clear margin, we'll recommend mastectomy. We used to remove level 1 and 2 axillary nodes at the time of lumpectomy or mastectomy. So there are three levels of nodes in the axilla. They are the nodes that are lateral to the pec minor, underneath it, or medial to the pec minor. And we used to remove all of those nodes in an axillary dissection, which really set the patients up for lymphedema. We've evolved from that to what's called a sentinel node biopsy, and we're going to talk about that a little later. The systemic control, to me, is probably the most important part of breast cancer treatment. The surgery we do, we need to get it out. We need to have clear margins. But what keeps people alive, as Allie will be talking to you about shortly, are medications. So hormonal therapy, if it's an estrogen receptor positive, progesterone receptor positive cancer, which means it likes estrogen, it likes progesterone, it's fed by those, we can use anti-estrogen therapies. And to me, that's one of the most important parts of the treatment. And then we have chemotherapy, which also saves lives. There are some new chemotherapies available. I want to just mention, we took ER positive, PR positive. The other big marker is HER2, HER2/neu. Patients who have HER2 positive tumors, we have new targeted therapies to block HER2, and those are called trastuzumab, Herceptin, there's pertuzumab. These drugs have revolutionized the treatment of HER2 positive breast cancer. It used to be pretty much a death sentence, and now I have seen patients with big tumors, axillary nodes. They get preoperative or what's called neoadjuvant chemotherapy with chemo and a HER2 agent. I've seen the masses totally disappear. The node's gone. You can't see the mass on MRI anymore. That's called a complete pathologic response. We've done lumpectomies on them, rechecked their nodes, no tumor. Another new therapy now is what's called palbociclib. It's a CD4/6 inhibitor. And this is used for women who have ER positive, PR positive metastatic disease. It's used in combination with an anti-estrogen and with really good results. Bone mets in breast cancer are not a death sentence. And Allie's, I'm gonna hand the mic to her so she can talk about that. But I just want to also tell you that I was in the supermarket the other day and ran into one of my HER2 positive breast cancer patients who had liver mets diagnosed 5 years ago. She's 50. before the anti-HER2 therapies, she was HER2 positive, she would have been dead in 6 months, right? This was 5 years ago. She looks better than I've ever seen her, and her liver mets on scan are gone. So it's really exciting, and there's so much more coming down the road with the new therapies. So,
Hi, everybody. How are you? Thanks so much for coming today. My name is Allison Yeagle. I am 51. God, it goes so fast. I'm just going to start at the beginning really quickly and tell you a little bit about myself. So when I was 38, I was in bed reading a book, and I felt a lump underneath my right arm, right around here. I said to my boyfriend at the time, "Oh my God, what do you think this is?" He's like, "Oh, it's nothing. Don't worry about it. We'll go to the doctor. We'll check it out." This was in, oh my God, I don't even know when was that? Thank you, maybe 2005, actually, 2005. So 12 years ago. I went to my doctor. She checked it out. She told me at this time, so this is 2005, she said, "You know what? Why don't you wait? Let's wait 6 months. It seems small. We're not sure what it is. Let's wait." Got home that night. My boyfriend, again at the time, said to me, "You're going to drive me freaking crazy with this. Let's go back and ask them to do something." So we actually went and had a ultrasound, actually. I was sitting in, as a patient, I was sitting in the room. They did the ultrasound, and it was all really dark and quiet, and there was nice music. And they didn't come back. The doctor didn't come back, or the person didn't come back. And they didn't come back, and they didn't come back. And finally, the radiologist came back and said, "I'm really concerned about this. I think this is cancer." So immediately I was, I have cancer. Oh my God, what's going to happen? Oh, again, 2005, I was 38. This is something that I really was not expecting. It's kind of messing up my plans. So from that point on, I met Dr. Palladino. I had a great oncologist, Dr. Hammond. I met with Amy, who kind of took me through everything. I was young. I was going to get married. I went through in vitro to try to save, because they assumed that I was going to go through menopause if I was going to have chemo or radiation, et cetera. So I did that. I had a lumpectomy. I went through chemo for 8 months. Then I went through 8 weeks of radiation. That ended in October of 2005, and I figured I was done. And I was done by that time, let me tell you. So because I was young, I decided against taking tamoxifen. It was offered to me, but I wanted to have a baby. I wanted to get married, have a baby, and so I did that. So in July of 2007, after getting married in 2006, I had a wonderful little girl named Lily, and life was fantastic. 2011 rolls around. I am out golfing with my now husband, and I swing, and I hear a crack. And it was literally like a crack. And I thought, what the heck was that? Now, mind you, from 2005 to 2011, every 6 months I was seeing Dr. Palladino, or I was getting a scan. I mean, I was good. I was getting MRIs, I was getting mammograms, I was good. So in April of 2011, I hear a crack. As a busy mom and as a professional, I was like, I don't have time for this. I will just take some Advil, and I'm sure I'll get some physical therapy, or I'll do something, and it'll feel better. I waited 8 weeks, and then I went to the doctor, and I said, because I'm a doctor, I'm not a doctor. I said to the doctor, "You know what, I don't need any x-rays, I don't need anything, just give me some physical therapy. I'm sure that's what it is. I'm sure I just hurt something back there." He agreed. So I did physical therapy for 10 weeks. During that 10 weeks, I also went to a chiropractor who was, pretty much leaning on my body and cracking my spine. Finally, the chiropractor said to me, "Allison, let me see, you're not getting better. Let me see your films on this. Let me see your x-rays. And I was like, I never got x-rays. He's like, you never got x-rays. Go back to your doctor, get some x-rays. I got to see what's going on here. Later that was like on a Monday, or that was on a Friday. On a Monday, I got a call saying, I hate to tell you this, but we think you have metastatic breast cancer throughout your bones. So talk about lucky. I had that chiropractor pressing on me. He probably could have like completely paralyzed me, but he didn't. But that's what I get for not actually listening to my body and actually going to the doctor and actually getting x-rays. So that was really crazy. So I was to that point, I was sneezing and not feeling my lower legs. Talking about not being aware. I mean, it's just crazy. Now, thankfully now people are being more educated so they can see when you have breast cancer and then later you have bone pain or something, good idea to go to the doctor and get it checked out. So I went on steroids, hydromorphone, I believe, steroids for a bit. I had my doctor, my oncologist, and actually Diane and Amy looking at me like, oh, this is bad. I remember my husband at the time saying, okay, so we're going to give her steroids and we're going to do radiation therapy on her spine. But what does this all mean? Like, we're not, like, what's happening? And he got up and he walked away. And I turned to Diane and Dr. Hammond and I said, well, wait, I'm not going to die, am I? And they both looked down. And I thought, well, this isn't good when your doctor doesn't look you in the eye and looks down, right? So I will always remember this, and I know he hates that he said this, but my doctor at the time said, well, you do have about 31 months. And every couple months when I would beat that, when I would get past 31 months, I'd say, I beat that 31 months. And I'm still beating that 31 months, which is awesome. So I did the radiation therapy. I was on tamoxifen. I went on tamoxifen. In 2012, I had an ovarectomy, and then tamoxifen started working, or stopped working. I don't know how much you know about metastatic breast cancer, but we pretty much take medications until they fail. And so tamoxifen started to fail, and so then I went on Arimidex. So I was on tamoxifen for 3 years, then Arimidex for 3 years. Went on Arimidex right after I had my ovarectomy because that's for a postmenopausal person. And then, I'm blanking. So after that, 3 years later, after on Arimidex, I went in, I had scans. Thankfully, it's only in my bones, and like Diane said, metastatic breast cancer to the bone is not necessarily a death sentence. And so thankfully, it has not spread anywhere else for me. But it did start to show that it was spreading a little bit. So 5 months ago, I started on Ibrance and Faslodex. What's the term for palbociclib? Palbo. This is where it is very interesting for me because this drug, whereas Arimidex and tamoxifen, I pretty much didn't have to think about cancer at all. It just felt like it was being controlled. I didn't have any side effects. Every 3 months I'd go in for a bone scan, PET scan I would go in for every 6 months, but I would also have, why am I blanking on this? No, biophosphate. Yes, I would have that every 3 months, and that would bring me down a little bit because it felt kind of like I had a flu, and that would be an infusion. But that's the only time I had to think about it. All of a sudden now, I'm going to the doctor every week, getting blood tests, having blood drawn, taking these pills that are making me feel horrible. And again, my white blood count would go down. I would fall asleep automatically at 2 o'clock, no matter where I was. Just intestinal difficulties. So all of a sudden, cancer became a big thing for me, because then all of a sudden it made me realize, oh gosh, wait, what do I have to do here? Where's my quality of life? So while Ibrance they have great commercials, the reality for me was, even though we tried many different versions of it, 125 milligrams, 100 milligrams, 75 milligrams, I've recently decided to stop taking it because my quality of life was just not good. I was always in bed. I have a 10-year-old daughter who constantly needs my attention, a husband, a family, a job. So that's an interesting way to look at quality of life versus treatment. And I think we'll go.
I'm going to make you love her even more now, because the day I told her she had breast cancer, I can still see her sitting across from me with Lawrence, her husband. And I told her that the biopsy came back and this was indeed breast cancer. And she stopped, she paused, she looked at me, she tilted her head and she said, "This must be so difficult for you." A patient had never said that to me and has never said it to me since, after 45 years of being a surgeon. The other thing I would just want to comment on her, she's blaming herself because she didn't get the x-rays, right? That's not her fault. It's the ding-dong doctor or PA or physical therapist who didn't ask her past medical history. Breast cancer, back pain. Ding, ding, ding. It's a no-brainer. So it's not your fault. So again, breast cancer is driven by change. We just talked about some of these meds that are saving lives. When I was an intern, we did radical mastectomies. We took the whole pectoralis major out, the minor out. We took so much skin that we had to take skin grafts from the leg to put on the chest. I'm going to show you a picture of one soon, and it was debilitating. Now we go to these little small, there's this hidden scar surgery that's being done where you look at the patient, you would never know she had breast cancer. I'm going to show you some of those pictures. And we've gone from axillary dissection to sentinel node biopsy, and sometimes now we're even skipping the sentinel node biopsy. So here's the point in the lecture where everybody wakes up and gets juiced up, and then we can take it from here. Boobs! This lady had bilateral mastectomies. Okay? I'm not lying. This is a patient who had bilateral nipple-sparing mastectomies. You can't see the scars. They're hidden in the inframammary fold. She also had a sentinel node biopsy. She was a BRCA carrier and wanted bilateral mastectomies. So we make the incision underneath the inframammary fold. You can also do a circumarelar incision. If you have to do a sentinel node biopsy, which you don't always have to do if it's prophylactic and you've had an MRI first, you don't have to extend the incision up towards the axilla. We dissect all the breast tissue out from under the skin. The borders of the breast are the clavicle, the inframammary fold, the sternum, and laterally the edge of the latissimus. All of that tissue comes out, and then we put an implant in under the muscle usually, flap the skin back, and that's the desired result. Some women end up losing their nipple because of devascularization. You have to pick the right patient. We won't do it in smokers because they have poor blood supply. But this is revolutionized mastectomy, and it's also a reason why some women are opting more for mastectomy because they get such a good cosmetic result. This is a radical mastectomy. You can see she's had a skin graft there in the middle, and you can see her ribs because her pec major's gone. So we have come a long way, haven't we? This is also a lady who had a mastectomy, not quite a good result. You can see the brown discoloration of her skin is because she had post-mastectomy radiation therapy, which is sometimes indicated. Another bad result, modified radical mastectomy. This is a skin-sparing mastectomy. The patient had her nipple and areolar complex reconstructed after the surgery. But none of them are as good as this. One of the things that's helped us, another new advance, is the acellular dermal matrix sling. That's that skin that's down on the bottom. It's from cadaver skin. So remember, when they harvest you, tell them to take your skin. And the pec major down there gets very thin, so when we lift it to put the implant under, it sometimes tears, and you can actually see the implant through the skin. So with this cadaver skin, we sew that in place, and it covers the bottom part of the implant and holds it up in place. So this is a bad lumpectomy. We're also trying to fix this kind of problem with creative techniques. So she had the cancer removed there in the upper outer quadrant off the edge of the nipple, and then she didn't have a nice tissue, what we call oncoplastic surgery, where you move flaps to fill that defect, and then the radiation made that scar pucker in more. This is a lady who also had a lumpectomy. See the difference? This lady presented on the left after lumpectomy. She had a really large breast on the right, a lot of asymmetry. So she had a breast reduction with a lift on the right and the same thing on the left, and, you know, fixed that puckered scar. So, you know, breast cancer does not have to be something that leaves a woman not feeling whole. Lymphedema is a definite problem, especially with axillary dissection, and if you compound that with radiation therapy. The risk of it is much less now that we're doing sentinel node biopsy, but certain patients are at higher risk, especially obese and elderly patients and patients with diabetes. Amy, do you want to say a few words about lymphedema?
Well, I should ask the DPT students about lymphedema from this morning. We had 2 hours on it today, so good timing. But for really everyone in the room, when we think about the management of lymphedema, there are a lot of comorbidities that go along with it. The risk of cellulitis is there, so prescriptions and monitoring for signs and symptoms of infection. There's a lot of stigma that goes along with it. There's people that have lymphedema that people unfortunately will stare at a large extremity, and it's embarrassing. They try to cover it up. There's lots of things that go along with that. From a management perspective, obviously we know complex decongestive therapy consisting of manual lymphatic drainage, some compression bandaging, some different compression devices. Skin care and exercise is really the hallmark of what we know is effective in treating lymphedema. So that could be PT, that could be OT. There are nurses, licensed massage therapists who can become certified lymphedema therapists. So it's something that can be really interprofessional, and making sure that you're communicating with the patient as well as the patient's provider as far as things that they need. We talked this morning about patients who can have a rapidly developing cellulitis, that they need to know what that looks like, and ideally have a script on file so that if they are developing an infection that they can end up getting treated early. So it's something that in Maine, primarily occupational therapists treat lymphedema. Other states, it's treated by PT or both. It sort of varies geographically, but it's an important area to be able to address. Early detection is now really coming into play. There's a prospective surveillance model that says, let's not wait until somebody gets cellulitis or gets a more advanced case of lymphedema. Let's try to catch them early. Let's screen them and get a baseline. There are different assessment techniques that you can actually see preclinical lymphedema mathematically on like bioimpedance testing instead of waiting to see it with the naked eye. So there's lots of really great technological advances in that area, but it really, again, it takes a village. So lots of people involved with the treatment of lymphedema.
Great, thank you. Yeah, we send our, if we feel the patient's going to be at high risk for axillary dissection, we'll send them to physical therapy preoperatively, and they'll do impedance measurements, as Amy says, and then they repeat those measurements every 3 months for a while, because again, the earlier you can diagnose it, the earlier it can be treated. We used to measure with measuring tapes, but this is much more accurate. Also, now there are some surgical techniques for lymphedema being done at specialized centers, where they're using microscopic surgery to anastomose lymphatics to little tiny veins. And there's also lymph node transfer procedures being done, where they'll take nodes from the groin and implant them into the axilla. So sentinel node biopsy, I don't know, should I skip this? How are we doing on time?
No, I mean, you're fine.
Okay, so instead of removing, so breast cancer likes to go to the axillary nodes first, and so it's important for chemotherapy decisions to know whether the patient has axillary disease. So the risk of lymphedema with this procedure is much less, 5 to 8% versus probably 25%. And what we do is we inject around the areola a blue dye. It's called isosulfan blue dye. It's picked up by subdermal lymphatics and travels up to what we call the sentinel node. The sentinel node is the first node or nodes that drain the breast. So although we talked about those 3 levels of nodes, the sentinel node can be anywhere in that chain. So it's not like you just go and take the bottom level, level 1. We also inject a radioactive substance like technetium sulfur colloid into the breast and use a handheld Geiger counter in the operating room, which beeps when we get to the sentinel node. So the sentinel node accurately predicts what's going on in the rest of the axilla. If you have a negative sentinel node, you are very unlikely to have other positive nodes in the axilla. So that spares the patient that axillary dissection, which is by far in a lumpectomy the worst part of that surgery, the most debilitating and the most a risk for nerve damage and lymphedema. So another new development, just briefly, is when patients have radiation, as Ali told you, she had whole breast radiation, that's on the left. It's usually 6 weeks of treatments, daily treatments with a linear accelerator. People started to think about brachytherapy, which is local therapy to the tumor bed with radiation. When breast cancer recurs, it almost always, after lumpectomy, it almost always recurs right where it was initially. So the thinking is, why are we irradiating the whole breast? Why don't we just irradiate where the breast cancer was? So this started these partial breast radiation techniques. What we use at Exeter is IORT, that's intraoperative radiation therapy. We actually did one of these yesterday. At the time of lumpectomy, we insert a balloon catheter into the lumpectomy cavity. This is an older technique called Mammocyte, where after that, the patient went home with this catheter and had twice-a-day treatments for 5 days, and then we would pull the catheter. We use IORT, which is a one-shot deal right in the operating room. So we put the balloon catheter in, the radiation oncologist comes up with his machine or her machine. We shield the breast, we shield, you don't need a lead-lined room. It's not a radioactive source. That's our rad-onc pushing the button. I tell him that's his big job. I do all the work and he pushes the button. We've had really good results with this. We've done about 150 now. We've had 2 recurrences. Both of those recurrences were my patients who would not take tamoxifen. So I go back to that hormonal thing. To me, that's the most important thing. And this is one of the reasons mastectomies are increasing. MRI is very sensitive, but it's not as specific for breast cancer as we like. So it often shows us things on the other side. The women have to end up having multiple biopsies, and they're like, I'm done with this. Just get rid of the breasts. So once we get all of this information, the pathology, any scans, we really need to come together as a team. As Professor Littorini says, it does take a village. The best way to treat breast cancer is with a team approach. This is an old team at Exeter, but we have the radiation oncologist. The woman with the funny hat is a plastic surgeon. We had a research specialist and an oncology nurse. There's our friend. You recognize her? She's sitting next to the pathologist. Across from him is the radiologist. And so we would sit together, go over everything. We had physical therapy there, social work, navigation, research. And then after we had come to a conclusion, we would meet with the patient, and males get breast cancer too, remember that, but only about 1% of all breast cancer. And we would tell the patients what our recommendations were. We would give them a written copy of those recommendations, because a lot of times they're like deer in the headlight and they don't remember one thing you said. A good technique when you're going over something difficult with a patient is to, at the end of your interview, ask them what their understanding of your conversation was. You'd be surprised how little they remember or really understood. Do you want to say anything else about multi-dis? Okay. What's coming? Tumor ablation techniques. Surgeons are going to be out of business someday, hopefully, breast surgeons. Radiologists will be able to take these tumors out, put a little catheter in there, and blast the thing. And as long as there are clear margins, hopefully the results will be good. So it's an exciting field. There's a lot going on. And that's all I have to say.
So thank you, Dr. Palladino. So what we would like to do now, can you guys come up and sit in the front, please? So we do this a little bit differently every year. And so what I'm recognizing is, Ali told you a lot of information in a relatively short period of time. So I want to sort of double back to that and really, you know, have you think about in your own roles or your own settings within your discipline a little bit about what she said. And so from the physical therapy perspective, I sort of go to that and I think about my students listening and thinking about, and it goes to any of you, but the physical therapist was the first person who, besides the PCP, that had sort of an opportunity to delve a little bit more deeply into the history prior to initiating some sort of treatment. And I just want to clarify that the PT actually did E-stim and some traction, traction, E-stim, manual joint mobilizations. I believe a Feldenkrais roller was involved, laying on it on the spine. So now that we know what we know about her spine, which essentially she was presenting with spinal cord compression, so that sort of those zingers going down the legs and the symptoms that she had, that was an emergency. But it was not recognized, and then it was sadly not recognized by the chiropractor, who, you are correct, they were doing high thrust manipulation that could have ended very poorly. So there were some missed opportunities, and so when we think about take-home message and why Ali and Diane have been so gracious to come up here and do this for UNE for so many years, is to try to have you all have a perspective of your your roles and responsibilities of being sort of early detectors and having a healthy suspicion for things when you have a patient who has a history of cancer. So one of the challenges for me was, and I was not the PT who treated her for 10 weeks, just to be clear on that, but Allie did ask me to call her. So when we did know what was going on, she asked me to make the phone call and have that conversation with that. This was an outpatient physical therapist in a private practice in Exeter. And that was not an easy conversation to have, but it had to happen, right? So that was something that I will always remember. And so, you know, our approach to the multidisciplinary clinic is something that is really a unique opportunity where we all come to the table with our different perspectives and our different objectives that we want to make sure we cover with the patient as far as patient education and opportunities to answer questions. And, you know, if I remember correctly, it was Valentine's Day.
It was.
You came to see us on Valentine's Day for the breast clinic. And so can you describe for the audience, and then we'll have Diane also talk about the multidisciplinary experience that day, and then we also had the day in 2011, we had a multidisciplinary experience then as well.
So as a patient, like Amy had said, you walk in there and your brain is just swirling. And I actually just had a conversation today with somebody about how when you do go to these sort of meetings with doctors, to always have an advocate with you, someone you can trust to take notes. He'll be level-headed, probably not your mom or your child, but somebody, you know. But I remember walking in there with my fiance, and there was, I think, oh gosh, there was a social worker, there was you, there's Diane, there was a radiation oncologist, my oncologist at the time, and I feel like there were a couple more people, but I don't remember. But the best thing about it was each person took a little bit of time out of their busy schedule to talk to me about what they thought I needed, what treatment I needed, and how they were going to help me through. And then the beauty of it is I had that time to ask questions of everyone at one time. And so, you know, when you're brainstorming, it's better to have a team, same thing. It was great to have that. And my husband had said, you know, he was thrilled, again, because there's nothing like a group of minds. And so it was fabulous. So I highly recommend it to anybody who ever talks to me about their treatment, to make sure that the hospital has that interdisciplinary piece.
Yeah, I have two sisters with breast cancer, and that's what kind of made me get on the breast cancer bandwagon. I was a general surgeon who decided after that I was going to be the best breast surgeon I could be. And that's why I started the multidisciplinary clinic where I was in Philadelphia, and then brought it here when I came here, because it's the best way to treat a lot of cancers, especially breast cancer, lends itself to the multidisciplinary approach. So here we all are, all together on the same page at the same time, looking at the pathology slides, looking at the images, listening to the social issues going on with the patient, which are plentiful, and impact treatment. And, you know, things don't fall through the cracks. It's not like, oh, I'll have to call the oncologist and see what he said about, or she said about that. We're all together at the same time, on the same page. So it's like the perfect package for the patient, and that's what we're all about, right?
Well, and I also want you to, if you could double back to when, you know, ultimately how the reaction of other people when you, in 2011, you have talked over the years about that sort of reaction from other people, or not knowing what the reaction should be, or that. Do you know what I'm talking about?
Like,
right, correct.
Not in that.
Not in the moment.
Not in the moment.
You can talk about that too. But
talking about when I told other people
Right.
what I had, you mean out in
Yes.
real life? So, so of course, after my 2011 diagnosis, we, as a couple, my husband and I, and of course, at that point, my daughter was 4. so we didn't think it was good. I mean, it was obviously somebody giving you so many months to live is devastating. I mean, devastating. And one of the things that I thought was interesting is when I would tell people, this is what I have, this is what they said, people were pretty much mourning me right then and there. So I lived that first year and a half with people actively mourning me because they thought I was going to be dead soon. Very difficult. Thankfully, my team at Exeter helped me through that. I'm obviously here today. It's just, and my doctors, like, they knew, it was so nice to have that group of doctors who were always right there with you and really understood the emotional impact of what was going on. So is that?
It is. Yeah. So one of the other things that I think was helpful for Allie, but is helpful for cancer survivors in general. So as I sort of listed that village of individuals that it takes to help support a cancer survivor, can you relay some of the things that you did? Because Allie's not your average patient. I think you guys probably got a clue about that already. So your sort of endless positivity and motivation and willingness to try anything and sort of do anything put you uniquely positioned to take advantage of the wellness program.
Yes,
but can you
yes.
talk about some of the things that you actively did to support yourself?
Sure. So in that meeting, I started, when I was diagnosed in 2005, one of the things that I did take part in was it was called a Cancer Well Fit program. And it was awesome because every Tuesday and Thursday, there were a bunch of people, other cancer fighters and survivors, and a bunch of physical therapists. Every Tuesday and Thursday at 4 o'clock were waiting for me to walk in that door. And I would warm up, I would do weights, everything very specific to my cancer. I would see Amy, I would see some doctors. So it was nice to have that continual support. Again, it's all about support. Some of the other things that I did, I'm just trying to think what else I did. I was very active in the community. I didn't shy away from talking about what I had. I felt like the more people that knew about my cancer, metastatic breast cancer, the better off people would be, because I didn't know, you know, if I would have known, I mean, the minute I had back pain, I would have gone to the doctor and said, what the hell's going on here, you know? But I didn't know that, so education is key. I got very active in my daughter's school. I just lived life as much as I could, and I'm still doing that. And reaching out and talking to people and trying to educate people on all sorts of things. But, yeah.
So lymphedema, did you ever have any symptoms of lymphedema?
I did not.
Excellent. And so from a standpoint of the Cancer Welfare program that Allie's describing, we ended up doing, it was a hybrid program of cardiovascular exercise, progressive resistive exercise. It was circuit weight training. We had a whole CYBEC set, and flexibility. And so with the initial treatment, as I said earlier, fatigue can be profound. So fatigue associated with chemotherapy, sometimes neuropathy associated with certain chemotherapy agents can be problematic, but really fatigue is the number one reason we would see people in that fitness program. And we were spoiled. We had a 40,000 square foot health club that we had access to. So our patients took advantage of that. But then after her diagnosis in 2011, we actually had a research study going on at that time looking at the benefits of exercise for patients with advanced cancer. So what we did was randomize our patients, any patient with a stage 4 diagnosis, or in the event of like multiple myeloma stage 3, the terminal stage of the disease, we ultimately randomized them to either strength training or cardiovascular training, and we looked at the benefits of both, and actually both had benefits. So if you think your patient can't lift weights with metastatic cancer, you might be wrong. You have to be careful, certainly, and you have to refer them to somebody who knows what they're talking about. You can't just send them to Planet Fitness and say, go gangbusters. But you need to be pretty astute with where the lesions are. We look at things like cross-sectional diameter. I had access to the radiology imagery over at the gym, so we knew and were able to have conversations and made sure that we were prescribing things that were appropriate. So that's a big key. And then you have continued in various exercise capacities since then. But some of the other opportunities that we had for our cancer survivors were acupuncture, we had yoga, we had massage, we had art therapy, we had traditional support groups, we had an artist on staff who had an art cart that would go around to the different infusion bays in the chemotherapy area. We had pet visitors who brought in certified animals. So there were, many people that were there to assist our patients through their treatment. And I would like to say one thing about thinking about the mentors that you might secure in your career. And I try to remind people of this every year, that my first mentor was a PhD research nurse. And so she is the one who really got me to a level of understanding of oncology, but also research methodology, Vicki Filer. And then Dr. Palladino and Dr. Hammond, a medical oncologist and a surgeon, were also my mentors. I had PT mentors too. I'm not saying PT mentors are not a good thing, but don't underestimate the value of a mentor from another discipline. So if you can latch on to somebody who has the willingness to give and the energy to teach you, latch onto them like a barnacle, because you need to have people like that in your life. And so I just felt so blessed, and Dr. Palladino and I have had this conversation a lot, to be able to learn from her and also everybody else around me. So look for those people, find those people, and take advantage of that.
Well, and right back at you, because I learned so much from you, from your physical therapy side, from your empathy, from your knowledge of breast cancer. And Amy actually started that WellFit program at Exeter, and it's an amazing achievement, and you're really lucky to have her.
So, well, we would love to open this up for questions, because I would hope that this has inspired a lot of inquiry from you. So we want to hear from you, if we could, please. We have a mic here available to you, so questions.
How common are these WellFit programs or similar programs, I guess in Maine, in the broader area? And I was wondering, is it a grant-funded thing? And I also had a second part to that. In these programs, do you teach like rest and activity balance? And because I know, well, you said that something that really helped you was activity and was doing and involvement, but is there education on the balance between rest and self-care versus really engaging in your quality of life?
I would say that the prevalence of them is increasing around the country. So there are some Livestrong programs that are out there, particularly in southern Maine. The YMCAs have Livestrong programs, but a lot of cancer centers are initiating some of their own programming. So it was a little bit more common in New Hampshire and Massachusetts than it is up here from a medical model base. So I would say at Exeter Hospital, because we had the connection, because I worked for the cancer center and I was a physical therapist and I was working with amazing PTAs and trainers in that exercise program, that we were a medical model. So something at the YMCA doesn't necessarily have that direct connection, but they can. And so when I talk to those folks, which do amazing work, is to remind them to have that conversation and that sort of connection with local therapists, local providers, and make sure that everybody is communicating, because that's really key. So they all do that very well. But I think they're increasing in number across the country, as our oncology rehab programs in general are increasing across the country. And the second part of your question was about rest and balance. Yeah, so energy conservation is really important. So in our medical model of our program, at least, which is not the same in, let's say, a Livestrong program, we were able to take a patient who would be perhaps in a wheelchair on oxygen and we could still prescribe exercises for them safely and appropriately. Whereas maybe another program, they would be excluded. That exclusion criteria might be such that they would not be able to handle a patient with that level of medical acuity. So I think it depends on the program. But yes, I mean, we had a lot of patients who had baseline dyspnea and really, whether it was primary lung cancer or metastatic lung disease or just anemia or cancer-related fatigue, that balancing of rest is really key. So thank you for bringing that up. We have to have another question.
Earlier on, you said that the percentage of cancer in people 65 and over should be increasing by 2020, and I was just wondering why that is with all the new treatment and everything coming out.
Well, we're still going to have cancer, unfortunately, even though we're better at treating it. Cancer is, generally speaking, not in all cases, but statistically speaking, a disease of aging. So when we think about acquired genetic mutations, those usually happen over time. So the statistical incidence of cancer is higher in patients over age 65. So when we think about, and although the thinkers in geriatrics don't like the term silver tsunami, but when we think about the number of patients who are going to be crossing that threshold of 65, that number is going up. So then in turn, statistically, that's going to ultimately increase that number of cancer survivors just by nature of the aging population in this country. So there will definitely be, that will be an effect.
I have a question for you. What do you think about Allie's decision to stop the Palbo?
I actually kind of had a question about that, so I'm not going to answer. I'm going to ask another question. But so you talked about that and how you decided to stop taking it because you realized that your quality of life wasn't where you wanted it to be. So what were some of the things that you did to kind of replace it once you stopped taking it and increase your quality of life? What were some of the things you did?
So I actually just stopped taking it last Wednesday. I am on Faslodex, which is a hormonal, an injection that I get every month. So we, as a team, we decided that we would see how, because I have a slow-moving cancer, thankfully. And so as a team, we decided my quality of life was pretty low. What if we stopped that? I have to also say that one of the side effects of Ibrance is a very low white blood count, and my neutrophils are under 1,000 right now, so not good. And so that risk factor, the idea of just being so tired that I couldn't really function, and just some of the other side effects. So what we're doing is we are going to stay with just the Faslodex shots for the next couple months. And in about 3 months, I don't know for sure, 3 or 4 months, we'll do another PET scan. PET scan has been my scan of choice throughout my disease. And now we don't really want to change that. So we keep with that. So we'll see how, if anything progresses, or if the Faslodex is actually still helping me, and the Zometa, those infusions, I'm still doing those. So, does that answer your question? Okay, thank you.
My students have a course participation percentage in their weighted total for 710. There we go. there's a mic. Oh. I was working. I worked for Timberland in Stratham, New Hampshire. So what I did was I continued to work. I started going into work once a week, or I'm sorry, 1 week while I was off chemo, and then I would do chemo that next week and kind of recover, and then I'd go back to work. But by the time radiation came around, I was just so beat
and just needed to take a break. So then I stopped. And then I went back to work right in October, actually, after everything was done. And then when I became pregnant, I left them in 2007. But they were great.
We talked a little about early detection of breast cancer, and I had a question about mammograms and what the current recommendations are. And my understanding is that those recommendations have changed and there's some controversy around it. And so if you could explain that a little.
Yeah, you're right. There's a huge controversy about mammography. The preventive, I forget the name of the United States Preventive Task Force, came out with some recommendations which decreased the screening intervals, increased the age to start screening. And there was a big pushback, mainly from the American College of Radiology, because radiologists like to do mammograms. I mean, mammogram does, and the American College of Surgeons push back, because the more mammograms you do, the more breast cancers you're going to find. But the question is, are you going to change the outcome of that patient with early detection? So the other downside of it is we're diagnosing all of this DCIS, which is ductal carcinoma in situ, which is where the breast cancer starts. Most breast cancers start within the duct. And until those cells multiply and break out of the duct into the surrounding breast tissue, that's invasive breast cancer. So that's what we treat with surgery and chemo and radiation. DCIS is treated in a lot of ways, not with chemotherapy. And there's a question as to whether all DCIS will become invasive breast cancer. DCIS is found on autopsy in a lot of women with that has obviously never progressed to breast cancer. So the treatments are to get it out. Sometimes women have mastectomies for DCIS, but now there's a small study being done in California where the DCIS is found on mammogram, biopsied, left in place, and if it's ER positive, the patient's placed on tamoxifen or an anti-estrogen medicine, and they follow her. So one of the arguments against frequent mammograms, especially in young women, is we're finding things that maybe aren't going to be a problem for the patient long term. The other negative thing about it is often there's a lot of false positives with mammography, especially in young women with dense breasts. So it leads to unnecessary biopsies, anxiety, that kind of stuff. So currently, our college recommends screening mammograms yearly starting at 40. Some of the other colleges say start at 50. The other important question is, when do you stop? In England, they stop at 70. In this country, pretty much it's look at the patient. You know, if you have an 80-year-old who's got renal failure and diabetes, and, you know, breast cancer's not going to kill her, so maybe you can skip that mammogram. It's a controversial question, you're right.
Well, and I know this is a breast cancer talk, but there is a controversy in prostate cancer as well. When you think about the advent of the use of PSA, we found a whole lot more. You look at the spike in the diagnosis of prostate cancer incidence, it was really the implementation of PSA. So those prostate cancers were there, we just weren't finding them, but then it becomes the question of what do you do about it? Does somebody have to have a prostatectomy or radiation to the prostate when they have prostate cancer? We know the statistics are that if men live long enough, the majority of them over age 75 are going to have some degree of prostate cancer. Will it end their life? Probably not. The 5-year survival rate for prostate cancer is 100%. treatment. So we overtreat prostate cancer terribly. So there are things like watchful waiting, which is not usually recommended because that's like watch and wait until the other shoe falls and you come in with back pain. That's not really a good strategy. But active surveillance is a very viable strategy for prostate cancer as well. And so if we know somebody has biopsy-proven prostate cancer, can we watch it? The problem is here. And can patients know they have cancer in their body and sit there and leave it there? Because that is a really tough concept. Or can their significant other live with the fact that they know they have cancer in their body? So there's a lot of influences of what happens there. But that is a real concern that going forward, we should be not over-treating, but let's treat what we need to treat. Find it, sure. Find it early, yes, but let's not treat it to the point where it's excessive.
And one other thing about the mammography is you have to individualize it to the patient. We started a high-risk clinic at Exeter where we see women who have increased risk for breast cancer. We have computer models where we plug in your data, age at menarche, age at menopause, family history. And we can actually come out with a number that shows what your risk for the development of breast cancer is. Some of those women need to have yearly MRIs as well as yearly mammograms, and the age to start that will depend on the risk.
Any other questions? There's a hand, or is that a hand, or are you touching your forehead? She's touching her forehead. Okay. It looked like it. Hi.
So one of the things that I would like all of you, as you go out and begin your careers, when you meet with your patients and you understand their background, this was said to Amy by Dr. Hammond, who was my oncologist and fellow doctor at Exeter Hospital. When somebody in your purview has pain and you know they have had cancer, he said, always use the ABC, ABC theory, which is always believe cancer. So always believe cancer when somebody who has previously had cancer and they are saying they have pain. It's just a really good way to think. I knew you were going to say
Exactly. Yeah. Well, I had forgotten it. Denny would be so upset at me. But so yeah, keep that in mind. And when you think about a new symptom that has not yet been diagnosed, that is on you to push to make sure that that diagnosis is made. So having a healthy suspicion for things like cancer-related emergencies and/or metastatic disease it really needs to be on everybody's radar. More times than not, it's not. But sometimes it is. So you have to be prepared for that zebra to walk in your office and not miss it. If it's hoof prints, most of the time it is horses, but you all know that saying. So, all right, so any other questions? You guys have been awesome. We really very much appreciate your attention and attendance. Thank you.